Welcome to Inside 340B Report, an insightful conversation between 340B Report's editorial team on the key issues affecting the 340B drug discount program, the nation's second largest government drug program. Hello, and welcome to the latest episode of Inside 340B Report. I'm Ted Slafsky, 340B Report's publisher and CEO, and I'm pleased to have our great editorial team join us for our twice-monthly discussion of key developments in the 340B drug pricing program. Today's episode is particularly special since it's our first recording since the recent promotions of Will Newton and Shannon Young. Will has been elevated to editor-in-chief, and Shannon has been promoted to managing editor. Will and Shannon are not only top-notch journalists, but they are great analysts who do a terrific job of explaining a very complicated federal drug discount program in a cogent and compelling manner. I also want to thank our national correspondent, Luke Zarzecki, who has been with us for 6 months, for his excellent contributions to the team, including several news scoops. Not only am I very proud of you guys, but I know our subscribers greatly appreciate the public service you provide to our growing audience. So congratulations to you all. First of all, turn to you, Will. Congratulations. Any thoughts on your new position and all of that?
Yeah, thanks so much, Ted. I'm really excited about the opportunity and love working with Shannon, Luke, and you. And so I'm excited for all of the new reporting, analysis, and scoops to come on the 340B program.
Well, great. Congrats. And Shannon, thank you for all of your great work and congratulations to you.
Yeah, thank you, Ted. It's always nice to have your work appreciated. Like Will, I also really enjoy working with this team and covering a very complicated subject, but working with you all makes it a little bit fun and somewhat easy. So I appreciate that.
And Luke, keep up the great work. You've been doing a great job. I love your enthusiasm and eagerness to get to Capitol Hill and get all those scoops that you've been getting for us. So thank you, Luke.
Yeah, thanks, Ted. It was great to join earlier this year, and I love getting to learn about 340B. I do think I learned something new every single week, and it's been great working with you guys.
Excellent. So great. Before we dive into the latest 340B developments, I want to let our listeners know that we're pleased to offer a special 25% discount to 340B Report first-time subscribers. You can go to the subscribe tab at 340breport.com and use the coupon code podcast25 to take advantage of the discount. I know you will find our news service to be a valuable investment. Also, I want to encourage you to check out 340B Report's business-focused podcast, 340B Leaders Upfront, hosted by Anna Mangum. The podcast showcases conversations with industry executives who are at the cutting edge of innovation and leadership in the 340B space. There have been several major 340B developments since our last episode. Today, we will discuss 3 major 340B program legislative proposals that have been introduced in Congress just recently, CMS's proposal to slash Medicare Part B reimbursement to 340B hospitals, and the latest responses to manufacture in-house claims data policies, including a lawsuit by a teaching hospital against one of the big drug companies. So let's start with talking about a draft bill that was put together by the chairman of the Senate Health Committee, Bill Cassidy, a Republican from Louisiana. Can you tell us more, Shannon?
Yeah, Ted. So I feel like there's not an episode that goes by where we don't discuss Bill Cassidy. As Ted mentioned, he is the chairman of the Senate Health, Education, Labor, and Pensions, or HELP Committee. And this committee has oversight over the 340B program. And so that's part of the reason we discuss him so frequently. Another reason is that he's been a very vocal critic of the 340B program as it currently stands and has advocated for a lot of reforms to the program. He launched a multi-year investigation into the program, which he re-upped a little bit earlier this year. He's called for various changes. And so this bill that came out on June 25th was sort of a preview of coming attractions of sorts. It's a draft discussion. So it's not a full-on bill. It doesn't have a bill number or anything, but it contained a lot of proposals of things that Cassidy would like to see done to the program. And notably, he gave stakeholders and the public, other lawmakers, whomever, until the end of August, so August 28th, to provide feedback on this discussion draft. And it would, among many things, allow drug makers to offer 340B rebates, add provider reporting requirements, codify certain contract pharmacy uses, and reform the 340B prime vendor program. So these are a lot of hot button issues we've seen taken up in different bills in different states, or just debates we've had at the federal level. And so these were all come in this discussion draft. And so to get into the specifics of what this would do, it would allow drug makers to give 340B discounts either upfront or through a rebate model via a Health and Human Services Administration administered claims repository. So covered entities could choose to receive the upfront discounts or rebates if they agree to pass along all of the savings to the patients. And so this is a major change to the program. And providers argue that it would rob them of savings that they need to provide a variety of comprehensive and affordable healthcare services like mobile clinics, transportation, and language services. So that's a pretty controversial provision. Other parts of this draft discussion include it would add new hospital reporting requirements, allow contract pharmacy use with certain limits, reform the fee structure for pharmacy benefit managers and third-party administrators. It would codify a narrower 340B patient definition. This has also been a pretty hot topic in the 340B world. It would set new requirements for hospital child sites. It would cap the number of contract pharmacies a covered entity can work with and require them to be located in a covered entity service area, among other things. It would also require HHS to allow covered entities to select from at least 2 340B prime vendors and add restrictions on the prime vendors' activities. Prime vendors must be, quote, free of conflicts of interest, end quote. They cannot charge covered entities for educational services, and they must, quote, provide unlimited rights to HHS to data created or managed through their prime vendor contract. It would also bar them from negotiating procurement of non-340B related products on behalf of covered entities. And so, again, this is a lot of different moving parts here. This is all just a draft proposal. And it's also noteworthy because, as you may remember from a couple episodes ago, we discussed how Cassidy lost his reelection bid in the Senate. So he is not returning in the next Congress. So he will continue to chair the Health Committee through the end of this Congress, which will be the end of December, early January. And so it's kind of unclear exactly what he's looking to do with this. It's not clear whether this bill has a lot of legs. Cassidy has famously sparred with President Donald Trump in recent months. It remains to be seen whether this is anything that will go anywhere or if this is Cassidy just sort of putting out his last offering of what he would like to see done with the program. And so, yeah, that's an overview of what is in this discussion draft.
Yeah, that's super interesting. And you mentioned we don't really know what happens with the bill next, but that doesn't mean that all of the 340B stakeholders have kept quiet about this. I know there has been a whole lot of commentary on it. So can you kind of dive into what different players are saying?
Yeah, so of course, I mean, the reactions to this bill were kind of as to be expected. You know, as I said, Cassidy really hasn't been the best friend of 340B provider advocates. The drug industry has liked a lot of proposals he's called for in the past. And so the reactions kind of fell along those two lines. So provider advocacy groups, including 340B Health, the American Hospital Association, Advocates for Community Health, and others raised, quote, serious concerns that this proposal would hurt hospitals and health centers that rely on the 340B program. So among them was Maureen Testoni, who's the president and CEO of 340B Health, who said it, quote, includes sweeping proposals that would profoundly alter 340B and make it more difficult for safety net hospitals to use 340B to provide essential care to patients in need, end quote. We also had Amy Coleman, who's American Hospital Association's Vice President of Advocacy and Grassroots, who told 340B Report that AHA was still reviewing the proposal, quote, but any meaningful 340B legislation must address drug companies' attempts to take over control of the 340B program. And a National Association of Community Health Center spokesman said that NAC looks, quote, forward to working with Chairman Cassidy and his fellow members of Congress to strengthen the 340B program to ensure access to medications and care are available for those who need it most. They also noted that the 340B program is, quote, essential for community health centers, end quote. So again, provider advocates were not super happy about this. The drug industry largely lauded this proposal, arguing would help fix the program and root out alleged fraud and abuse. And this is a line that pharma and other drug industry groups have been pushing for several months now in various high-figure ad campaigns, especially in the Washington, D.C. area. So that's not too surprising. So pharma spokesman Chance Jones said the trade group supports the Senate Health Committee's efforts to, quote, fix the 340B program and ensure it works for patients. And they added that for too long, the program has been exploited by bad actors, driving up costs for patients, taxpayers, and employers instead of directly benefiting low-income and uninsured patients. They also said that they look forward to working with the committee and stakeholders to advance meaningful reforms that ensure 340B delivers savings to patients, not profits for hospitals and clinics. John O'Brien, who's the president and CEO of the National Pharmaceutical Council, which is a health policy group composed of large drug manufacturers, that reform is long overdue and the signals positive progress. And so, again, that's kind of along these two tracks. It's not that surprising, but that has sort of been what we've heard so far. And then let's switch gears a little bit. There was another major 340B related bill that was recently introduced in Congress, Luke, that you covered. What can you tell us about the Secure 340B Act?
Yeah, so shifting over to the House side of Congress, on July 6th, Representatives Scott Peters, who is a moderate Democrat from California, and John Joyce, who is a Republican from Pennsylvania, they introduced the Secure 340B Act. And as some listeners may be aware, Peters represents a district in the San Diego area that has many biotech companies and has been one of the only Democrats to support bills that have been often opposed by 340B providers. And Joyce is a dermatologist and is a co-chair of the GOP Doctors Caucus, and he has not been too active on 340B in the past. And so this bill would pause 340B rebate models for 4 years while a new patient definition is created, and it would allow contract pharmacy uses and add new reporting requirements and also add new transparency and data sharing measures. It would also direct HRSA, or the Health Resources and Services Administration, to use an independent clearinghouse to manage prescription data, verify claims, and protect privacy. The bill would also mandate charity care reporting for hospital sites, establish new eligibility standards for hospital child sites, change requirements for hospital financial assistance and patient billing practices. It would add new reporting obligations for 340B compliance requirements and establish a 0.1% user fee on covered entities' 340B drug purchases. And the bill was co-sponsored by a few representatives that included Dan Crenshaw, who is a Republican from Texas, Nanette Barragan, sorry if I did not pronounce that correctly, but she is a Democrat from California. And it notably was co-sponsored by Jake Auchincloss, who is a Democrat from Massachusetts. And Auchincloss also co-sponsored a bill earlier this year that would exempt community health centers from any proposed rebate model for the 340B program. And he also published a blog on a Substack after we had already published our stories on the new bill. And he said that none of the stakeholders are fully happy with the bill. He wrote, "Nobody is fully happy, but various hospitals, clinics, patient advocates, employers, drug makers, and community oncologists all support the bill. It's a compromise, not just across party lines, but across sectors within healthcare. The reforms will lower health premiums and help strengthen Medicaid."
That's really interesting, Luke. As somebody who's covered politics in Massachusetts in the past, I'm not surprised that there's been some pushback from hospitals, which are a very powerful lobby here. So it's interesting to see Auchincloss comment on this in his Substack. Can you tell us a little bit about what some of these other reactions to the bill have been, specifically from different stakeholders?
Yeah, so the reactions were pretty mixed, and not just along the typical provider drug industry dichotomy. It was a pretty mixed bag, including the National Association for Community Health Centers, or NAC. They said that the provisions allowing the use of contract pharmacies, providing a 4-year delay of any potential rebate model, and having a neutral clearinghouse were really important. Advocates for community health, who represent large community health centers, said that the bill reflects its members' goals for reform. And Boston Medical Center, New England's largest safety net health system, said that the bill's long-term regulatory certainty through bipartisan solutions will help providers plan for the future. The bill also has support from the Community Oncology Alliance, who represents private oncologists and has critiqued the 340B program in the past. They said the bill has important steps for transparency, accountability, clear patient eligibility, stronger oversight of child sites, and patient affordability protections. The Community Oncology Alliance has corporate sponsors that include pharmaceutical manufacturers. Now, for those who critique the bill, it was also a mixed bag. America's Essential Hospitals, they said that the bill misses the mark by imposing burdensome requirements on hospitals while making concessions to the pharmaceutical industry. An attorney for the Ryan White Clinics for 340B access said the bill's patient definition, limitations on contract pharmacy and referrals, and user fee provisions are, and I quote, akin to a cruel child using the sun and a magnifying glass to destroy a colony of ants. The attorney noted the focus on direct patient assistance ignores the fact that 340B savings are used for other services other than discounting drugs, and that it plays into the pharmaceutical lobbying group's false narrative that patients don't get a benefit. In a different view, the Community Access National Network, a health policy institute focused on HIV/AIDS that lists multiple drug manufacturers as corporate sponsors, they said a clearinghouse is not better than a rebate model and said it will only compound problems already seen with Apexis. The Pharmaceutical Research and Manufacturers of America, they did not respond to my requests for comment on the bill. So Ted, how do you think providers are reacting to this bill?
Well, that's a good question, Luke. I think there are elements of this bill that are going to get support from all different elements of the 340B provider community, such as the neutral clearinghouse, rather than having a drug industry controlled data claims resource to instead, this would be something that would be run by the government and presumably would be neutral without having a particular bias towards either the drug industry or the providers. And I also think that they're going to be excited about the pause on rebates. That is all very positive. I would think that's what the providers are thinking. On the other hand, I know that hospitals in particular have some real concerns with the proposal or with the bill itself, because, for instance, it looks like they would no longer be able to use 340B discounts when they're discharging a patient from the hospital. This has been a common way that the 340B program has worked for several decades. So that would be a significant reduction in savings and also could increase costs for patients. And I think there's some real concerns about the cutbacks in the use of 340B in child sites, as well as concerns about being required to provide even more detailed information to the government than is currently required. This is all, on top of the requirements that the drug industry continues to insist on. So all of this is just a challenge for hospitals, particularly at a time when they're about to get major Medicaid cuts.
Very interesting. Switching gears to Shannon, you've been covering a Ways and Means hospital transparency bill. Could you tell us a little bit more about that?
Yeah, Luke. So on July 1st, the House Ways and Means Committee held a markup on a bill known as the Tax-Exempt Hospital Transparency Act. And so this bill would require certain nonprofit hospitals to report new 340B data on federal tax forms. So this bill came as somewhat of a surprise. It was introduced on the Monday that week and then marked up just a couple days later. The House Ways and Means Committee is a pretty powerful committee in Congress. It has jurisdiction over federal tax issues and some health policy. And Rep. Gregory Murphy, who is a Republican from North Carolina, who sits on the panel and is a practicing surgeon, introduced the bill. And so the quick kind of movement on this bill is really interesting and noteworthy, just because it signals that there's a lot of appetite among Republican leadership for this legislation. So it will be something we're keeping our eye on for sure. But just to dive into some of the specifics of this bill, under it, certain tax-exempt 340B hospitals would have to report the total number of patients by insurance coverage type to whom they dispensed or administered covered 340B outpatient drugs during the tax year. Also, their aggregate net 340B payment amount for drugs administered or dispensed in the period, and their aggregate cost for participating in and complying with the 340B program. The requirements would not apply to critical access hospitals or rural emergency hospitals. And just as a note, this legislation came just a couple weeks after the House Ways and Means Committee held a hearing in which they had hospital leaders there and were, really grilling them on a bunch of different transparency issues. And 340B was a topic of conversation at this hearing. So it wasn't really that surprising to see these proposals come up in this bill. Representative Jason Smith, who's a Republican from Missouri who chairs the Ways and Means Committee, who had a lot to say at the earlier hearing, said during the markup that the legislation's update of the IRS 990 Schedule H form responds to investigations that found the current reporting requirements are, quote, woefully inadequate and make it, quote, possible for these entities to hide potential abuse of the tax code. Murphy, who sponsored the bill, said there are some problems with the 340B program, and the bill's reporting requirements are, quote, not overly burdensome, end quote, and provide the public and policymakers with necessary information to make informed decisions about whether or not certain hospitals are judiciously using ever increasingly scarce taxpayer dollars. Representative Richard Neal, who's a Democrat from Massachusetts and the top Democrat on the committee, was pretty vocal against it, as were other Democrats on the panel. And he said that this bill makes good on Republicans' quote, long-standing desire to undermine and disrupt the 340B program. So that's just a little bit of the coverage we had on that bill. If you want to read more on what lawmakers had to say, you can read our story on our website. But it was a very noteworthy bill and something, like I said, we will be keeping our eye on because it looks like it will be seeing some action, at least soon in Congress.
Yeah, that'll be interesting, Shannon. Whether it makes it through the Senate, that's another barrier, as we all know. But certainly it's interesting that it passed an important committee. We shall see with, as you know, the limited time left in the calendar. So before we continue, I want to just take a moment to hear from one of our great sponsors.
The rebate pause didn't remove risk. It raised the stakes. As manufacturers expand data demands and tighten controls, pricing integrity has become the first line of defense for 340B programs. Proximity treats pricing as a living system, monitoring every claim to surface silent pricing failures before savings are lost. A mid-size FQHC using Proximity typically sees a 16x return from identified pricing errors alone. To learn more, reach out to hello@proximityhealth.com. That's hello@proximityhealth.com.
So, Will, right before the July 4th holiday, we got another news dump, which was the proposed OPPS payments for the upcoming fiscal year. That includes payments for Part B drugs to hospitals. And I know that there was a proposal in there that has not been exactly warmly embraced by the 340B hospital community. Will, can you explain that to us?
Yeah, definitely. So there was huge news out of CMS recently, and that news is that CMS is proposing to cut Medicare Part B reimbursement for 340B acquired drugs from its standard right now of average sales price plus 6%, ASP plus 6%, to ASP minus 33.4%. And that is a 37% relative decrease. So that is a huge decrease in how 340B hospitals would be reimbursed for Part B drugs going forward. CMS, as part of its proposal, basically said that this is going to save Medicare as well as taxpayers billions of dollars by reimbursing there. Hospitals were pretty opposed. They argued that it really undermined the 340B program's goal of supporting care for vulnerable patients. They say that the program is supposed to allow covered entities to stretch scarce federal resources to serve more patients. And so by removing their ability to generate savings on these 340B drugs to Medicare Part B, they had concerns there. And CMS did this after conducting a survey of hospitals, basically looking at their acquisition costs. And they said, based on the results they found, which is as expected, that 340B hospitals acquire Part B drugs at a lower price than non-340B hospitals, which is because they get the 340B discount there. So that was sort of the justification that went into this pretty important news.
Well, this seems like deja vu for 340B hospitals. Why is that?
Yeah, you're exactly right. It is because during the first Trump administration, CMS also attempted to cut Part B reimbursement and actually did cut Part B reimbursement. So that time it was by close to 30%. This time it's even more, by 37%. But what happened is that after CMS implemented these Part B reimbursement cuts for 340B hospitals, the Supreme Court ended up unanimously overturning those cuts on procedural grounds, basically saying that CMS had not gone through the proper procedures when it went around about surveying hospitals and implementing this. So what we know right now, at least from speaking to some sources and attorneys, is that it very much looks like CMS is trying to learn from its mistakes and avoid some of the legal pitfalls that basically hampered its first attempt at reimbursement cuts by doing a more comprehensive survey. That said, though, I think there's almost no doubt that providers and hospitals in particular are going to sue this once again. So it's deja vu on CMS, implementing these Part B cuts. It remains to be seen whether it's deja vu on the courts stopping these cuts once again.
Well, that's really interesting, Will. On another topic that you've been reporting on, as we have reported on a lot lately, a number of drug companies are now trying to require in-house pharmacy claims data in order to access 340B pricing. And Eli Lilly was the first drug company to begin to terminate 340B pricing for some hospitals in the program. And one of those hospitals, Tampa General, just recently sued the drug company, Eli Lilly. Can you tell us more about that, Will? That's an interesting court case.
Yeah, for sure. As you said, these manufacturer in-house pharmacy policies have gone into effect. Providers have been up in arms, sending HRSA letters arguing that these policies violate the 340B statute. But to date, HRSA has not really taken any definitive position. HRSA's spokesperson has told us several times that HRSA continues to review these policies, but has not taken a definitive position, has not said these policies are permissible or impermissible, which has sort of put covered entities in a tough spot because they don't really have a final agency action to sort of base things off of and go from there and challenge what HRSA is doing. But as you mentioned, Ted, one hospital in Florida sort of took things into its own hands and attempted to directly sue Eli Lilly through a new lawsuit filed in federal court recently. It's Tampa General Hospital. It's a teaching hospital in Florida, sued Eli Lilly and argued that Eli Lilly's actions to cut off 340B pricing violate Florida's Deceptive and Unfair Trade Practices Act. So that's sort of an interesting legal strategy. I know we've discussed in the past how, due to Supreme Court precedent, it can be pretty difficult for covered entities to directly sue manufacturers. Usually courts say they have to go through HRSA's processes. So this hospital is attempting kind of a workaround by saying that basically alleging that Eli Lilly is using its market power to coerce providers into having to pay higher prices than what a federal program otherwise dictates. So, this lawsuit was just recently filed. It really remains to be seen whether or not this will have success, whether this will go anywhere. But I would not, count on this being the only lawsuit. I think providers are really trying to scramble and see what they can do about this. There is a lot of alarms raised among the provider community when Eli Lilly became the first manufacturer, as you said, to actually cut off 340B pricing as a result of its in-house claims data policy. So I think this is just probably the start in the legal realm of what's going to come here. So we'll be continuing to follow that very closely here.
Yeah, we'll keep our Pacer subscription for another year as we continue to keep a close eye on all of these lawsuits. Pacer's the government website that tracks all of these lawsuits, and we spend a lot of time looking at Pacer these days. So with that, that brings us to the end of today's episode. We'll continue to keep an eye on all things 340B related, and we'll be back in 2 weeks with a new episode. Of course, we will report on anything that happens in the meantime on our website. Please follow along with our twice weekly newsletters. And just a reminder, if you're not a current subscriber, you can take advantage of our 25% discount offer for first-time subscribers only by going to 340breport.com and clicking the subscribe button using the discount code podcast25. Thank you for joining us, and we look forward to talking to you in 2 weeks.